Hello, future nurses. So today for pharmacology, this is Professor Flourish, and today in pharmacology, we are going to be talking about our cardiac medications part 2, which includes our coagulation modifiers, our antilipidemics, and our diuretics. So the first group of medications we're going to be talking about is our coagulation modifier drugs. So like with most of our subjects, what I like to do is start out with just a general overview. So the first thing that we're going to have a general overview on are our platelets. So platelets are also called thrombocytes. So thrombo basically just means platelets. So whenever you see thrombocytes, what you're thinking of are platelets. And these are blood cells that cause clotting of the blood. So they help blood clot by clumping and forming plugs. So on this picture here, you can kind of see how we've got a tear in this blood vessel here, and all of these platelets, see activated platelets here, all coagulate right here to stop the bleeding. If we didn't have platelets, basically we would bleed and bleed and bleed. Now, if platelets are too low, bleeding or bruising can occur. So thrombocytopenia is increased risk of bleeding. So penia means less than, so that's less than the platelets I need. So we've got some common causes of this, things like our medications, our autoimmune disease, our genetic disorders. All these different types of things can lead into thrombocytopenia. Now, once platelets are too high, clotting occurs. The normal blood value for platelets is 90,000 to 140,000 in the blood. Hemostasis, if you look at the word here, hemo means blood, stasis means to basically stop. So it's literally telling you stop blood. And what this is a general term for any process that stops bleeding. Coagulation is a hemostasis that occurs because of physiological clotting of blood. So this term here, when we say coagulation, we're talking about that clotting of blood. There's a complex relationship between substances that promote clot formation and either inhibit coagulation or dissolve a formed clot. So the medications we're going to be talking about will either inhibit coagulation or destroy the clot that already exists. Now there's two different terms, and I want you to get kind of more comfortable with these terms. We've got the term thrombus and embolus. A thrombus is a term for a blood clot. An embolus is a thrombus that moves through the blood vessels. So when you think of thrombus, what you're thinking of is stationary blood clot. Because the way I always look at blood is I call it the blood buddies, because blood always wants to be with its friends. And what basically happens is every single time blood kind of stays stationary, it starts clotting. So what you'll have is patients that don't ambulate and don't move around will end up developing these things called a thrombus. So they'll have like a big old blood clot inside their vessels. An embolus is basically when one of those thrombuses that moves through the blood vessels. So it can be a clot, it can be a fat embolus, it can be an air embolus. It's just something that moves and can lodge itself into a vessel. So our coagulation system is basically a cascade of events. So each activated factor serves as a catalyst that amplifies the next reaction. So something happens, then it leads into something else, and it keeps going on. The final result is fibrin, which is that clot forming substance. So you've got two different pathways, internal or intrinsic pathway, or external extrinsic pathway. So on this slide here, and I know it's kind of hard to see, what you have for the extrinsic pathway is external trauma to the blood vessels. So that might be something like I cut my hand. And what happens is a cascade of different events all take place, resulting into fibrin. Intrinsic means I had internal damage to a blood vessel. So that might be something like an aneurysm burst or anything of that nature. Something inside of me happens, and now I'm having a similar cascade of events that all leads into fibrin. So we can't just have fibrin after we've had our clot and everything's going okay. We need to get rid of that. And that's where you have the fibrolytic system. So this initiates the breakdown of clots and serves to balance the clotting process. Because if you think about it, if we didn't have something to stop this clotting process, we would bleed and bleed and bleed. Fibrinolysis is a mechanism by which formed thrombi are lysed to prevent excessive clot formation and blood vessel damage. So that's why we say your body has this like process where basically I have some sort of cut, I clot, and then when I'm done with that and everything's going back to normal, I've got other factors that come in to break up that clot. Fibrin is in the clot, binds to a circulating protein known as plasminogen. This binding converts plasminogen to plasmin, and then plasmin is this enzyme protein that eventually breaks down the fibrin thrombus into fibrin degradation. Sorry. Sorry, coughing. But so yes, it breaks down the fibrin thrombus into fibrin degradation products. This keeps the thrombus localized to prevent it from becoming an embolus. So this is what happens in a normal system. We've got fibrin in the clot, like we've already got our fibrin there, because remember, that's the ending result of all these different steps. And it binds this protein that's plasminogen, then converts, this binding converts plasminogen to plasmin, and then that eventually breaks it down, and then we no longer have the clot. So what happens if we've got a disorder? So some people have a disorder called hemophilia. Now with hemophilia, the disorder is, for some reason, I don't actually make the factors I need. So this is a rare disorder that's usually seen in more males than females. And the concern with it is that I don't have these hemostasis factors. They're either limited or absent, so I don't make them naturally. And basically what can happen to these patients is they can end up bleeding to death because they don't have anything to stop the bleeding. Now, the reason I bring this up is because with a lot of our medications, it is counterindicated to give these medications to somebody who has hemophilia. Okay, so jumping into our pharmacological overview. So with this, they modify coagulation. So we've got two different ways that they can do this. Most of the medications we give and most of the ones that we talk about are used to prevent clot formation. And I'll say that again, most of the ones like our anticoagulants or antiplatelets are all used to prevent clot formation. The other type, which is our thrombolytics, are used to break apart existing clots. So this is why we kind of shy away from the terminology blood thinner, because the only true blood thinner that you can have is a thrombolytic medication. So things like our TPA. So that's why you just want to be careful when you're talking to patients and just make sure that when you're talking to them, you're using the terminology of anticoagulant or antiplatelet. So medications work in the blood to alter the clotting cascade, preventing platelet aggregation or dissolving a clot. All carry a significant risk for bleeding. So every single one of these medications we talk about has a risk for bleeding. Your goal of therapy is to increase circulation and perfusion, decrease pain, prevent future or further tissue damage. So that's your whole goal of your therapy. So what I've done here on my slides is I've kind of split up your medications based off of what they do. So the first ones that we'll be talking about today are anticoagulants. So these are ones that stop the coagulation of our platelets. What we have is our heparin. So our heparins and then heparin, our low molecular weight heparins, which is our enoxaparin and dalaparin, and then activated factor XA inhibitor, which is our fondaparinux. So starting out, we'll talk about some of our heparins. So, heparin prevents clotting by activating antithrombin, which indirectly inactivates both thrombin and factor XA, which all inhibits fibrin formation. Once again, if you're looking at this, heparin is stopping the process of creating fibrin. It's not destroying the clot that's already there, it's just stopping the process. Low molecular weight heparins, like our enoxaparin and activated factor XA inhibitors, only inactivate factor XA. So heparin kind of does a few more things. Like I said before, it indirectly inactivates both thrombin and factor XA, while our low molecular weight heparins and activated factor XA inhibitors only inactivate factor XA. So what are our therapeutic uses? So our therapeutic uses for heparin are things like stroke, pulmonary embolism, massive deep vein thrombosis. And it can be used in adjacent for clients having open heart surgery. Low dose therapy can be used for things like prophylactics against postoperative venous thrombus. And it can be used for the treatment of disseminated intravascular coagulation. So this here is something that you'll learn about later when you get into your further med surges, but just as like a very quick overview of DIC. What happens in a patient who has DIC is that they're simultaneously bleeding while clotting. So it's kind of a balance act when it comes to the provider when they're trying to deal with this disorder, because they'll give them heparin, but then they'll also give them platelets. So that's why we say heparin is a therapeutic use for this, but it's something that we'll kind of go into more detail when we continue on in the program. Low molecular weight heparins, this is our enoxaparin that we're going to talk about. These prevent deep vein thrombosis, treat DVT and PE, and prevent complications in angina, MI, and STEMIs. And MI is myocardial infarction. And if you remember from my last video, a myocardial infarction is that tissue death. Because remember, ischemia is lack of oxygen flow, infarction is actual death. You've got activated factor XA inhibitors, which prevent DVT and PE in postoperative clients. They treat acute DVT and PE in conjunction with warfarin. So that was a general overview of each of these for their therapeutic uses. Now we're going to get into more detail about the medications alone. So that's why I kind of sectioned them off, because these are the things that are important about these particular medications. So the first one we're going to be talking about is heparin. So heparin is interesting in the fact that it can only be given through IV. Now, that being the case, we've got quite a few different complications. Some of our complications are toxicity, hemorrhage secondary to heparin toxicity, or possible other factors. So this can occur if medication administration leads to high activated partial thromboplastin time, which we'll talk about this more when we get into that portion of this lecture. Other factors include things like client history of bleeding disorder or taking antiplatelet medications concurrently. Another complication is epidural or spinal hematoma. Heparin increases the risk of a hematoma at a puncture site. Heparin-induced thrombocytopenia. So this is evidenced by low platelet count and increased development of thrombi, which is mediated by antibody development or white clot syndrome. So what can sometimes happen is I don't have enough platelets, so some of my other blood cells might jump in to try to fix that problem. Hypersensitivity reaction, things like chills, fever, hives. For that, one of your nursing actions may be to administer a small test dose prior to the administration of heparin. So heparin toxicity. One of the things that you want to know and make sure that you know is the antidote. Anytime there's an antidote for a medication, know what that antidote is. And the reason we stress this so much is because if you are on a very busy floor and a doctor tells you, I want the antidote for heparin, or they say, go get the heparin antidote, you want to know right off the bat what that is. Now, don't be afraid if you don't know it when you're actually on the floor to ask them what it is, but you do want to be comfortable with knowing antidotes. So for heparin, the antidote is protamine sulfate, which what this does is it binds to heparin and forms a heparin protamine complex that has no anticoagulant properties. So if we give too much heparin, then we can give this medication. Now it should be administered slowly, no faster than 20 milligrams per minute or 50 milligrams in 10 minutes. You do not exceed 100 milligrams in a 2-hour period, and administer carefully to prevent protamine toxicity. So like I said, you just want to be careful with this. Because the thing about heparin is a lot of times, not a lot of times, we are the ones that control, for the most part now, we're the ones that control the rate that heparin goes at. We do it based off of our heparin protocol. So you want to make sure that you're being careful with this when you're administering it. So the other one that we talked about for complications is hemorrhage secondary to heparin toxicity. So for this, our nursing actions would be to monitor our vital signs, advise clients to observe for bleeding, monitor your activated partial thromboblastin time, and stop infusion if hemorrhage occurs. So you really do want to assess your patients. Like on here, I've got this woman here who's got a big old bruise, and you can tell her blood vessels in her eyes have ruptured. And you want to make sure that you're watching them. So looking at this, why do I want to watch my vital signs? And I'll give you a second to do it. You can pause the video if you want to answer it before I answer it. So I'm looking for hypovolemic shock, because what can happen is if I'm bleeding out or anything like that, if I'm losing a lot of blood, then I can become hypovolemic. Or there's other ways that we can look at different shocks, but I won't go into all these different shocks. So you want to see, is my blood pressure dropping, my heart rate going up? Because one of the main signs of shock is heart rate going up, blood pressure going down. With it, like I said, you want to monitor your patient for obvious signs of bleeding and the not so obvious signs. So obvious signs are things like this poor woman here where she's got that big old bruise and you can see the tissue here. Not so obvious signs are things like your GI bleeds. So you want to look for those dark tarry stools. Your activated partial thromboblastin time is a test that if they're on a heparin protocol, we use all the time. It's to make sure that we are effective with our therapy. Because ideally what you want it to be is between that 60 to 80 seconds. And basically what this partial thromboblastin time is, it's just kind of telling us how long does it take for me to clot. So epidural or spinal hematoma nursing actions. So you want to monitor the patient carefully for any neurological changes. This could indicate a hematoma development. So it's very important that you know that a lot of these anticoagulants are counterindicated if somebody has an epidural. Now, in the case that somebody gave heparin and then they put in an epidural, you want to know what to look for. So what you're looking for in that case would be neurological changes. And if you think about it, it makes sense, because if you've got a big old hematoma here pressing and compressing against the spinal cord, then that's going to make it so they have neurological changes. Now, if you see that your patient has an epidural or they get placed in epidural and you've got an order for something like heparin or enoxaparin, you do want to talk to the provider before you just administer it. Make sure it's okay with the provider before you do it. So heparin-induced thrombocytopenia, you want to monitor platelet count periodically throughout treatment, especially in the first month, and stop heparin if platelet is less than 100,000. So your counterindications, heparin is pregnancy category B. It's counterindicated in clients who have low platelets, and it should not be used in the following surgeries: eyes, brain, spinal cord, lumbar puncture, or just regional anesthetic. And you want to use cautiously with patients who have hemophilia, increased capillary permeability, dissecting aneurysm, and peptic ulcer disease. And if you look at all these cautious, it all has a similar theme where we're trying to watch out for bleeding. Interactions, antiplatelet agents can increase the risk of bleeding, and garlic, ginger, and ginkgo can all increase risk of bleeding. If you remember, we talked about ginkgo, what was it? I think it was about 3 weeks ago, we talked about ginkgo, and I told you, remember this medication when we go on to other ones. It's an over-the-counter supplement. And the reason I say remember it is because it really interacts with a lot of our anticoagulants, because they all cause that increased risk of bleeding. And the reason we talk about this one is because that's one that they can get over the counter. Garlic and ginger are both things they can get over the counter. So some of our nursing administration considerations. So it cannot be absorbed through the intestinal tract. So that's what I was talking about before. It must be given IV or subcutaneous injection. You want to have your baseline vital signs. So if my patient was hypotensive before, I want to know that before I give it to them. Baseline and monitor APTT, platelet count, and hematocrit levels. So your APTT is your main one that you look at, because that's the one that's going to determine what you do next on your list of steps for the heparin protocol. Platelet and hematocrit are helpful in the sense that you just want to keep a good regulation of what you're losing here, because hematocrit levels is your RBCs, so that's your red blood cells. Platelet is the number of platelets you have. Read label carefully. Yes, I cannot stress this enough. Make sure that you are reading your heparin carefully, because it is given in a variety of concentrations. So this is why we stress so much during our dosage calculation that you know concentrations. And the reason for that is because a hep flush or a heparin flush that we use for a central line is a much lower dose than the heparin that we give subcutaneously. However, when you go into the OmniMed, if you just type in heparin and you grab one and not the other, you can end up causing a huge med error. So that's why I say, make sure that you read the label carefully. Make sure that you're not trying to go and not follow the rules of the policies of the hospital. Check with another nurse prior to administering. So I always check my heparin. Like, you're supposed to always check your heparin. That is part of the thing. You have to get somebody to co-sign it. But I'm the kind that I like physically got somebody to look at my pump, look at the computer, and make sure that those numbers were correct. And the reason that I was so adamant about it is because heparin is a serious drug. And what I don't want is to cause a med error with this. Use infusion pump. So you know what I've said before, if the medication can kill you with then it deserves its own pump. So if you're giving subcutaneous injections in the abdomen, ensure a distance of 2 inches from the umbilicus and do not aspirate. You want to monitor for bleeding. So things you can tell the patient are things like elective razor, and advise them to use a soft toothbrush. So on here you can see his little bleeding precautions. So the medication effectiveness. Once again, this is what we check when we're doing our heparin protocols. You want a APTT level of 60 to 80 seconds during treatment. So the next one we're going to be talking about is our enoxaparin low molecular weight heparin. So some of the complications that can be caused by enoxaparin are things like hemorrhage, neurological damage from hematoma formed during a spinal or epidural anesthetic, heparin-induced thrombocytopenia, and toxicity. So hemorrhage, once again, these are your nursing actions. You want to monitor vital signs, monitor your platelet count, and observe for bleeding. Things like increased heart rate, decreased blood pressure. Do you remember what I said before about increased heart rate and decreased blood pressure? Yes, they're signs of shock. Look how smart you are. Looking for things like bruising and petechiae. So this picture here shows petechiae. They always describe it as these like little purple dots. It kind of depends on which patient you're looking at, but what it really is these little kind of dots that are everywhere that can indicate that they have petechiae. You want to look for hematomas and black tarry stool. That black tarry stool indicates a GI bleed. And once again, you're avoiding aspirin. So neurological damage from hematoma formed during a spinal or epidural anesthetic. Okay, so you want to contact the prescriber if a patient has a new order for enoxaparin while on an epidural, or if they have a standing order. So one of our core measures, so we've got these things at the hospital that are basically like our core measures, things that are our little check boxes that we have to get in order for insurance companies to know that, hey, we're doing everything we need to do. It's kind of like, you know how you went before you went to the hospital, you had to have your flu shot, or you had to have all your immunizations. It's like that, but it's for like a general thing. So one of the things that we do that's a core measure is something called DVT prophylactics. Prophylactics means prevention of, DVT means deep vein thrombosis. So remember what I told you about a thrombosis. That is a stationary blood clot. Deep vein, stationary blood clot. So what happens is if I lay in bed, I'm going to end up causing a blood clot because I don't have that good blood flow. So in order to counteract this, what they do in order to help that is they've got a core measure where all your patients need to be on 2 types of DVT prophylactics. One is pharmaceutical and the other one is non-pharmaceutical. Your non-pharmaceutical are things like I'm going to ambulate my patient, I'm going to walk my patient, I'm going to use TED hose or SCDs. SCDs are basically these things that go on your leg that pump up air and keep blood flowing. Then you've got prophylactics, then you've got pharmaceutical prophylactics, which are things like your enoxaparin. So enoxaparin is used to prevent that DVT. So it's pretty much when the doctor goes in to put his orders in, he's got a bunch of standing orders. He's got a bunch of orders that are just there in the system. So he's going to click away, or she is going to click away all these things. So they may end up ordering enoxaparin. Now with that, just because it's ordered doesn't mean that you automatically give everything. What you'd want to do is if they go and they give them an epidural, you want to let the provider know so they can make a conscious decision of, do I want them to have the enoxaparin as well as have the epidural? And then from there, they can decide what you're going to do next. Now, in the case that they give enoxaparin while they have an epidural, that's when you do the second step of assessing insertion site for indications of a hematoma formation. So that'd be redness and swelling, and monitor sensation and movement of lower extremities. And you want to notify your provider if there's any abnormality findings. So like I said, this is a big roundabout way to tell you that if an epidural is ordered on your patient, or your patient comes back with an epidural, before you give that enoxaparin, you want to contact the prescriber and see if it's okay to give it. So for heparin-induced thrombocytopenia, you want to monitor your platelets and discontinue medication if platelet count is less than 100,000. Some of your counterindications and interactions. Counterindications, the thing is, enoxaparin is category B pregnancy. It's counterindicated in clients with low platelet, and a lot of these are very similar to our heparin. And once again, our interactions are the same thing. Antiplatelet, we're looking at garlic, ginger, and ginkgo. So the nice thing about heparin is you don't have to monitor it in the same way that you monitor heparin. So heparin, we're looking at the APTT, enoxaparin, or you've probably heard it called Lovenox. Monitoring is not required. They're acceptable for home use, and it's not like that continuous checking. If they go home on enoxaparin, you just want to make sure they have instructions for self-administration, such as things like rotate sites between right and left abdominal wall, at least 2 inches from umbilicus, do not aspirate, and inject entire contents of the syringe. So in this here, there's like a little air bubble, and what you do is when you press it all the way down into the skin, it's going to kind of pop, and the safety is located all within this whole syringe. So it's not like you have to do a different safety. You just press the whole thing and it goes in. So in order to see if my medication's therapeutic or not, you just want to see that there's no development or further development of venous thrombi or emboli. So the next one we're going to talk about is our vitamin K inhibitors, or our coumadins or coumarins. So this is our warfarin. So the pharmacological action, so this is our mechanism of action, is it antagonizes. So if it antagonizes, it blocks vitamin K, thereby preventing the synthesis of 4 coagulation factors, factor 7, 9, and 10, and prothrombin. So by antagonizing that vitamin K, it's stopping these 4 factors from formulating. Therapeutic uses are things like prevention of venous thrombus and PE, prevention of thrombolytic events for clients who have AFib or prosthetic heart valves, reduction of the risk for recurrent transischemic attacks or myocardial infarction. Now, the thing about these prosthetic heart valves, so like your mechanical valves, they're the people who are going to be on your anticoagulants for the rest of their life, because you don't want, it's very easy for it to clot around that mechanical valve. So some of our complications: hemorrhage, hepatitis, and toxicity. So once again, hemorrhage, we're monitoring vital signs, we're monitoring for bleeding. We obtain prothrombin time and monitor levels of PT and internationalized normalized ratio periodically. So that's your INR. And in case of warfarin toxicity, DC the warfarin and administer vitamin K. Hepatitis, monitor for liver enzymes and monitor for jaundice. All right. So toxicity. This is important. It's another antidote. Whenever you have an antidote, just make like a little list to yourself of this is the antidote. So in the case that somebody gets too much warfarin, what you want to give them is vitamin K1. And this promotes the synthesis of coagulation factors 7, 9, 10, and prothrombin. You administer vitamin K slowly. If vitamin K cannot control bleeding, administer fresh frozen plasma or whole blood. Now, one thing I want you to know the difference of is vitamin K is different than K plus. What is K plus? I'll give you a second to answer that. It is potassium, and potassium is very different than vitamin K. Vitamin K helps with clotting. K plus or potassium helps with conduction because it's a muscle conductor. So they do 2 different things, and you just want to make sure that you know that they're not the same. Okay. Okay, so these are some of our counter indications and precautions. So warfarin is a pregnancy risk D for clients with mechanical heart valves, and category X, which means no for baby, for other pregnant populations. So a lot of times what they'll give them instead is heparin or low molecular weight heparin. You want to warn mothers or not to breastfeed because the medication can pass through the milk. It's counterindicated with patients with low platelet counts and counterindicated with clients who have vitamin K deficiency, liver disorders, alcohol use disorders, causes that additive risk of bleeding. And you want to use cautiously in clients who have hemophilia, dissecting aneurysm, peptic ulcer disease, severe hypertension. So what I've done is I've split up interactions of medications and interactions with food. Warfarin, it's almost easier to look at a med and see if it interacts with warfarin sometimes than to like list all the things that interact with warfarin, because it can be a lot. So, and I'm not going to go through every single one of these. I just want you to kind of know that medications really do interact a lot with warfarin. They can either cause increased bleeding or decrease the effects of it. Now I am going to go through this one. The reason I'm going to go through this one is because it's very important that you know these foods. So I'll kind of start it with a story here. Um, some of you guys are at Park West and some of you guys are at Fort Loudon with me. And there's a Cracker Barrel right next to the hospital. And me and my sister, we used to work at Park West. She worked day shift, I worked night shift. And what we would do sometimes when our like schedules would allow it, like sometimes like if I did like a half a shift, anyway, we'd be out at the same time on rare occasions. So we'd go to Cracker Barrel together. And what we would always do is look at people's wrists. And the reason I say look at people's wrists is because so many people come directly from the hospital into Cracker Barrel where they all have their armbands from the hospital. So the reason I bring this up is because while a patient's at the hospital, we control their diet, correct? So that means that they're eating those leafy greens, they're taking their medicine the way they're supposed to. Everything looks great. Now, the problem is when they go home, they drive themselves right from Park West or right from whatever hospital they're at, and they drive themselves right to Cracker Barrel, where they are no longer eating those those dark green leafy vegetables. So I say this because dark green leafy vegetables can decrease the anticoagulant effects. So while they're at the hospital, their INR may have been 2 to 3 because that's what it's supposed to be. And we regulated enough medication and we increased their meds to be enough. Then they go home and they eat cheeseburgers for every meal. And now their INR is 7 to 8, super high. So that's why it's important to let the patient know that, hey, if you start eating salads here, you want to continue that diet when you go home. Because you don't want them to have that sudden, uh-oh, look at what I did. So foods that are high in vitamin K are things like your lettuce, your cooked spinach, your cabbage, your broccoli, Brussels sprouts, all of these kind of things that are big in vitamin K. The other thing is garlic and ginger. So garlic and ginger can increase the risk of bleeding. So you just want them to know that they can't have what foods and why they can't have those foods. Because you don't want to just tell them, oh, you can't have that without letting them know the reason behind it. So warfarin administration is usually oral. So that's why we'll start them out on heparin IV, and then we transition them to being on warfarin. Usually it's once daily, and recommendations say to take it at the same time every day. That way it has the same, this is when I take it, my body's used to it. You want your baseline vital signs, and the labs for this are PT and INR. So make sure that you know the difference between the lab values of warfarin versus heparin. Heparin is APTT, warfarin was PT-INR. Your vitamin K1 is your antidote, and you want to watch for bleeding. So this, once again, is how we measure whether or not the medication's therapeutic. So I kind of put different numbers on here based upon what was prescribed for the patient. So for your, because most of the time what we're looking at is your INR. So if they've got, like, for example, a mechanical valve, we're going to bump it up a little bit higher than those other ones. And the whole goal is to have no more development of further venous thrombi. So the next one we're going to be talking about is our dabigatran, which is a direct thrombin inhibitor. Once again, these are all ones that are stopping coagulation. So the way it works for your mechanism of action is it binds with and inhibits thrombin, thus preventing a thrombus from developing. So therapeutic uses are things like preventing stroke or emboli inclined to have AFib, not caused by valve heart disease, and to also treat DVT and PE. So this right here is a deep vein thrombosis. So this is our normal heart valve here, where we've got these lovely little valves that open. Here it's flowing fine. Then on a DVT, we've got all these clots where it's sticking. So we want to watch for bleeding. GI effects, back pain, nausea, hypotension, and headache. It's a pregnancy risk C. It's counterindicated with allergies or bleeding, and you want to use cautiously with clients who have liver impairment and use cautiously with kidney impairment. Rivampin decreases the levels, and once again, we're seeing that garlic and ginger, which increase the risk for bleeding. So some of your nursing interventions include oral capsules should be swallowed whole and can be taken with or without food. Containers should be used 30 days of opening, and discontinue other anticoagulants when starting this medication. Effectiveness is evidenced by prevention or reduction of thrombus formation. So the next one we're going to talk about is our rivaroxaban, which is a direct inhibitor of factor XA. I highlighted XA to kind of like remember it. It's rivaroxaban. So your purpose is it provides anticoagulation selectively and directly by inhibiting factor XA to prevent formation of thrombin. It can be used for stroke prevention. It can be used for patients who have AFib and prevention of postoperative DVT or PE and treatment for DVT. Complications, bleeding. We're seeing a common theme here. Everybody seems to be bleeding. This one is also hard on our liver, so you can have elevated liver enzymes and bilirubin. Once again, most of these are similar to what we've seen before. The thing is, you want to watch patients who have mild liver impairment or moderate kidney impairment, counterindicated with people who have allergies, and you want to use cautiously for anybody taking any other anticoagulants. Interactions, look at that. Garlic, ginger, and ginkgo. GGG. Seems like we always want to remember those three when it comes to our anticoagulant things. Once again, they all increase risk of bleeding. So rivampin, carbazepine, phenytonin, and St. John's wort can decrease these levels. Your nursing actions, you want to administer tablets orally, once daily with or without food, same every day, and you're monitoring your hemoglobin, hematocrit, and liver and kidney functions. So the next ones we're going to be talking about are our antiplatelets. So with our antiplatelets, each of these inhibit different factors. We've got aspirin, clopidogrel, epoxybin, and dipradamol. Your action is it prevents platelets from clumping together by inhibiting enzymes and factors that normally lead them to arterial clotting. They also inhibit platelet aggregation at the onset of clotting process, so they alter bleeding times. So what I say for antiplatelets, while anticoagulants stopped the formation of fibrin, so it stopped it kind of at the source, your antiplatelets are more just making it so your platelets aren't as sticky. So that's how they work with it. And that's why you can't really use these medications here as a DVT prophylactic, because they're not stopping coagulation, they're just stopping the ability to stick with one another. Therapeutic uses, prevention of MI, prevention of reinfarction following acute MI, prevention of ischemic stroke or TIA, acute coronary syndromes, and intermittent claudication. So I kind of wanted to talk briefly about intermittent claudication. Oops. Okay, let me make sure if this is recording. Yes, okay. So intermittent claudication is an arterial problem. And what happens is, for some reason, it's usually up here in your fem artery, you're not getting good blood flow. So there's some sort of narrowing of your vasculature. And with that narrowing, what happens is it causes leg pain. So that's what these medications are for, is to kind of help get better perfusion. Because you can only, it's like intermittent claudication. I always describe it as kind of like a Charlie horse almost, where it's like, oh my gosh, that feels terrible, because what you'll have is blood flowing, nope, and then whoosh, blood flowing, nope, whoosh. So that's why it kind of causes that. So that's what that intermittent claudication is. Routes of your medication, most of them are oral, except for Apocryphen. That's the one that is through IV. So complications, all of these are going to have bleeding. Now with aspirin, it can also cause hearing loss. So you want to look out for patients with their hearing. Apocryphen can cause hypotension, bradycardia. Clopidogrel, once again, GI effects, bleeding. Dipромil is dyspepsia, which dyspepsia just means indigestion. And the way I always remember dyspepsia is I think Pepsi gives me indigestion, and it causes nausea and vomiting. Interactions, concurrent use of medications that enhance bleeding. And there it is again, both garlic and ginger, because these can increase the risk of bleeding. Aspirin, caffeine can increase the absorption of aspirin. So the other thing too is aspirin can cause what's called Reye's syndrome. So that's why yeah, so it can cause Reye's syndrome in our teenagers and children. So you want to use cautiously with that age group. So clopidogrel should be discontinued 5 to 7 days before elective surgery. And with any of these medications, you do want to talk to the provider regarding your aspirin use, so that way they don't accidentally give you too much of it. Effectiveness can be evidenced by absence of arterial thrombus, adequate tissue perfusion, and blood flow without occurrence of abnormal bleeding. So the next one we're going to be talking about is our thrombolytic medications. All of these end in place, alteplase, tenecteplase, recteplase. And alteplase here is our most common thrombolytic we use, and that is our TPA. And what a thrombolysis does is this is the medication that actually dissolves a clot. So this one is a true blood thinner. So if you're going to use the terminology blood thinner, the only time you can use it is with thrombolytic medications. So like I said, they dissolve clots that have already formed. Clots are dissolved by conversion of plasminogen to plasmin, because remember way back at the beginning of this lecture when we talked about the other half of what's it called, our clotting system, this is the part that breaks it down. Therapeutic uses, all of them can be used to treat myocardial infarction, because all of these can dissolve the clot in the coronary artery. Now, ATP can be used for PE, ischemic stroke, and central IV catheter. Your complication, bleeding to the extreme, bleeding, and more bleeding. So every time that I have ever given TPA, my patient right after that has been on a 24-hour bed rest. And the reason for that, and it's strict bed rest, it's like, even though my patient is like a walkie-talkie, they're green level, they can go to the bathroom themselves, we are still putting them on bed rest because of this small chance that if they fall, they could end up having a hemorrhagic stroke. So that's why bleeding precautions is your #1 concern anytime you give a thrombolytic. So kind of just keep that in the back of your head no matter how far you go. Just be careful when you give these medications. So with that, our nursing actions make sense. We limit venipuncture and injections. So with it, no IM injections, we're going to wait. You want to apply pressure dressings to recent wounds, because remember, these are going to be destroying our clots. That means that we're not going to have the ability to actually clot. So you want to be careful with these patients. You want to monitor for changes in vital signs. Once again, I might have a GI bleed that I don't know about, so I want to see, am I losing blood somewhere? If I'm losing blood, then I can potentially go into shock. So I'm looking for things like increased heart rate, decreased blood pressure, alterations in level of consciousness. So you want to make sure that you're looking at your neurochecks, because if I have a change in my level of consciousness, that may indicate that I have a hemorrhagic stroke. You want to monitor your APTT, your PT, your hemoglobin, and your hematocrit. Client may require blood products. Now, luckily, this ATP can be reversed by aminocarpic acid IV. So nursing administration, use of thrombolytic agents should take place as soon as possible after onset of manifestations. So your onset of manifestations, we'll use the example of a stroke, would be if all of a sudden you see facial droop. It should be within 3 hours, but they can push it to 4.5 hours, but no more than that. And the thing about it is it's as soon as possible after the onset of manifestations. It's not when they arrive to the hospital, it's onset of manifestations. So what that means is it's the amount of time that we saw the changes in our patient. And once again, monitor your patients. I cannot stress this enough. You really do need to watch these patients. See, look at her. She's being a good nurse. She's watching her patient here. Okay, if you want to, you can put the video on pause and come back. Like I suggest taking a 5-minute break and then coming back and going through the rest of the lecture. This will kind of help you soak in what you just learned. Okay, so our diuretic topics. So these are medications affecting our urinary output. So our diuretics. So before we begin, I always like to kind of go through my anatomy, my pathophysiology, so that way we know what we're looking at. So a nephron is the basic unit of the kidney. So nephron is on the microscopic level. This is what we see in our kidneys. And what it is a sequence of tubes that filter the blood of waste and serves the fluid and electrolytes that the body needs. Each is surrounded by blood vessels where exchange of water and electrolytes occur between blood and tubular fluid. So what it is it's basically a filtering system where I drink a glass of water, it goes down to my kidneys, and basically I'm taking everything I want, filtering out through here, and then peeing it out. The glomerulus, waste removal and water recycling begins here. So in Bowman's capsule, what you have is this thing called a glomerulus. So it's these cultivated or like twisted little tubes where we take out what we want. So different sections of the nephron perform various functions in order to form a concentrated urine. Urine must contain all waste products, electrolytes, metabolites, and nitrogenesis or nitro compounds for excretion, and kidneys need to conserve the water the body needs. So in a normal process, that's what it does. So hormones that work at the nephron, we've got aldosterone. So that should be a refresher from when we talked about our antihypertensive medications, because remember our ACE inhibitors stop angiotensin 1 from becoming angiotensin 2, and all that leads into us, not producing aldosterone. So aldosterone causes sodium and water to be reabsorbed from the tubule into the bloodstream. Antidiuretic hormone causes water to be reabsorbed from the tubule into the bloodstream. So this right here are all the things that our kidneys do. So most people, when they think about the kidneys, they think about it filtering the blood. But along with that, it maintains our acid-base balance. It eliminates waste. It secretes renin to control blood pressure. It secretes erythropoietin to manufacture RBCs at the bone marrow. It synthesizes components of vitamin D, and it maintains glucose homeostasis by excreting or creating glucose. So when you think about that, if somebody has kidney problems, that's why they might also have a second diagnosis of anemia, because of all the things the kidney does. So starting out, I want to first talk about high ceiling loop diuretics. So these loop diuretics, it all comes back to the loop of Henle here. What we've got is furosemide and butamine, or furosemide and butenamide. Okay, so all these work in the loop of Henle. They block reabsorption of sodium and chloride and prevent reabsorption of water. Cause extensive diuresis even in patients who have severe renal impairment. So in this loop of Henle, what happens is the exchanges of salts. So sodium and potassium are like opposites of one another, which you probably talked about in your electrolyte conversations. So what happens is it causes that reabsorption of sodium, but it releases potassium instead, which ends up causing us to pee out a bunch of our potassium. So if you think about it that way, that's why we're always watching potassium with our loop diuretics. Therapeutic uses, it's used for emergent need for rapid movement of fluid, pulmonary edema caused by heart failure, conditions that don't respond to other diuretics. So with it, think about it this way. If I'm losing a bunch of fluid, what am I going to be worried about? Dehydration, hyponatremia, hypochloremia. Because we're losing sodium, we're losing salt. So if we're losing salt, that's sodium chloride. So we're losing both those things. Hypotension, if I have a big decrease of fluid, my pressure is going to drop. Ototoxicity, remember when we talked about, what's it called? Our antibiotics. So remember when we talked about gentamicin and how it can cause ototoxicity, that hearing loss, if it's given with loop diuretics, it's because they both have this ability to cause ototoxicity. Hypokalemia, remember with that loop of Henle, it's going to cause that hypokalemia. So other things are digoxin toxicity. If you remember from our last lecture about our digoxin, which is our heart failure medication, if you've got low potassium, it puts you at a higher risk of having digoxin toxicity. If I give a loop diuretic, that's going to cause my potassium to do what? Yes, fall. Concurrent use of antihypertensive medications can increase the risk for hypotension, and lithium levels can increase if hyponatremia occurs due to the loop diuretic. So lithium is a bipolar medication, and a lot of times what we worry about with it is our salts. NSAIDs decrease blood flow to the kidneys, so reduces the diuretic effect. So nursing administration, avoid administering medication late in the day to prevent nocturia. So nocturia is nighttime urination. So usual dosing time is 8 a.m. and 1400. So the best time is in the morning. Yay, with the little sun rising. And that's because we want to be nice to our patients. You don't want to give them something that's going to make them pee all day and then expect them to go to sleep, especially because think about it this way. Most of the patients that are on this medication are people who have heart failure. And if you have heart failure, it's usually because you're an older, not usually, but it's a lot of times because you are an older adult. And if you're an older adult, then you got to start thinking about things like delirium. Do I really want to give my patient who's got delirium, who's confused at night, something that's going to want to make them get up, walk, and pee? No, that's why it would be better to give it in the morning. You want to obtain baseline data, including orthostatic blood pressure, weight, electrolytes, and location of edema. Remember, we're always looking for that edema because we want to see, are they having signs and symptoms of heart failure? Remember our signs and symptoms of heart failure. That's things like, what's it called? Edema, weight gain, shortness of breath, difficulty breathing. Watch for patients on digoxin. Concurrent use can cause digoxin toxicity. If we remember our digoxin toxicity, that's things like our nausea, vomiting, we're seeing halos. We do not want to see halos, and watch for hypokalemia. And the next one we're going to talk about is our potassium sparing diuretic. So potassium sparing diuretic, the drug example is our spirlactolone. And the way I always remember it is you're sparing the potassium, so spirlactolone. And potassium sparing diuretics block the action of aldosterone. So that's that sodium and water retention, which results in potassium retention and excretion of sodium and water. So it works a little bit different. Instead of making that exchange where instead of keeping sodium, letting potassium leave, instead we're just blocking aldosterone altogether. And that way we're still keeping on to potassium, but we're excreting sodium and water. Now with that, your complications are going to be hyperkalemia. So if we think about it this way, what did I say about salt substitutes? What are salt substitutes also kind of known as in the NCLEX world. Potassium. So if you have somebody who's on spironolactone and they take a lot of salt substitutes, you may want them to kind of reevaluate what they're doing because they can end up going into hyperkalemia. It can also cause endocrine effects, so deepened voice, irregular menstrual cycles, all of these different things. And it's that spironolactone. So our thiazine diuretics. So these work in the early distal convoluted tubule. It blocks the reabsorption of sodium chloride and prevents the reabsorption of water at the site. It promotes diuresis when renal function is not impaired. So our thiazine, remember thiazine and calcium channel blockers work best in African Americans. Some of your complications are things like dehydration, hypokalemia, hyperglycemia, high uric acid, hypomagnesemia, and increased lipids. Osmotic diuretic, our lovely mannitol. So mannitol is, I always call it your super diuretic. You only use this medication when things are going bad. So it's used to reduce the intracranial pressure and interocular pressure by raising serum osmolarity and drawing fluid back into the vasculature in extraocular space. So with it is, do you remember way back in anatomy and physiology, or maybe it was even in your fluid and electrolytes conversation, where you've got isotonic, hypotonic, and hypertonic solutions? Mannitol is a hypertonic solution. So what it does is it basically shrivels up the cells, squeezes out all of their stuff. Like, let me show you here. Let me put this on pause and I'll find you a picture. Okay, just because I really like this picture a lot, I use it a lot. So you've got different kinds of solution here. Isotonic means whatever water I put in is the same amount of water I get out. Hypertonic is, or sorry, hypotonic is where I'm just putting fluids into the cells. And hypertonic is where I'm squeezing all that fluid out. And as a result, I'm causing my patients to basically pee it all out. Now, with this one is going to cause like a huge diuresis. So that's why we only use it for intracranial pressure. So intracranial pressure basically means that I've got too much pressure in my cranium. So it can be caused by something like an ischemic stroke, because right after you have an ischemic stroke, your brain swells and you only have so much space in your head. It's like if I bonk my knee, it's going to swell, but it has an area to swell. If I hit my head and cause some sort of damage here, or if I have a stroke and it's swelling, I don't have anywhere I can go. So your therapeutic uses are things like preventing kidney failure, decreasing intracranial pressure, decreasing interocular pressure. It promotes sodium retention and water excretion in clients who have hyponatremic and fluid volume excess. So some of the complications can be things like heart failure. So if manifestations of heart failure develop, you want to stop medications immediately and notify the provider. This is why our assessments are so important. You want to be able to see, okay, they gained 2 pounds in a day and they have a lot of edema in their ankles and they're short of breath. I need to let somebody know, because that means they're not peeing it out, it's just staying on their system. It can cause rebound interocular pressure, so you want to monitor for changes to your ICP. ICP is intracranial pressure. That's things like change of level of consciousness, your pupils, headache, nausea, and vomiting. So in NCLEX world, they don't go for like the fixed pupils. They'll always go for like projectile vomiting instead. It's like the odd man out. So if somebody has like ICP monitoring and you notice that they've got vomiting, that's usually the patient you want to see first, because that's indicating that they have increased intracranial pressure. Fluid and electrolyte imbalances, metabolic acidosis. So if you got metabolic acidosis, you want to look for things like drowsiness and restlessness. So nursing administration, it's administered by continuous IV infusion. And this is one of those medications that you need a central line. And you also need a filter when drawing from the vial and a filter in the tube lining. And that's because mannitol crystallizes. So as you can see on here, if you leave mannitol, it can crystal. It's the same thing that happens when it falls out of the actual tube or out of the actual infusion bag. You can see it crystallize. You want to monitor the patient's weight, blood pressure, and their ICP. Okay, so the next drugs we're going to be talking about are drugs used to treat dyslipidemias. So before we begin, I kind of want to talk about good cholesterol versus bad cholesterol. So you got a little smiley face versus a not smiley face. So HDLs are your good cholesterol. Good cholesterol are your high density lipoproteins, which carry excessive cholesterol in the blood back to your liver where it's broken down and removed from the body. This means high level of good HDLs can maintain your heart health. Bad cholesterol is your low density lipoproteins. Bad cholesterol carries cholesterol to your cells, but when you have too much LDLs, it can bind up in your artery walls, causing them to narrow. This reduces blood flow, which can be bad for your health. I put on some examples of food because you really want to get into the habit of knowing which foods are good for what. So LDLs are your good cholesterol. So that's things like winter squash, walnuts, spinach, tofu, all those kind of things that you want to eat. Bad cholesterol are things like ice cream, cakes, and alcohol. So HDL is excreted from the body. It's cardioprotective because it carries cholesterol away from the arteries to be excreted. LDLs cause arterial damage and is deposited inside the artery. So what happens is it deposits this LDLs into the arteries. So white cells try to basically eat the LDLs. So they perform these lipid-laden macrophages called foam cells, which leads to larger collections of fat, fatty streak, which then leads into inflammatory mediators and platelets, which all results in atherosclerotic plaque. So what happens is you've got these LDLs that kind of hang on the side of the vasculature here, and then white cells try to eat it. They almost, I don't want to say they give up, they almost give up, cause this little foam here, and then this fatty streak, and then it just basically becomes very, very hard because it's almost like they're sealing it off. And that's what leads into this plaque because you're not having good blood flow if you've got all this plaque here. Anti-lipidemics work by lowering low density lipoproteins and raising high density lipoproteins. They can possibly decrease very low density lipoproteins, but their main goal is to lower low density lipids and raise high density lipids. Now with these, they're not going to break plaque that's already been formed. This is all about prevention. So it's usually used in adjacent to lifestyle modifications. So things like healthy diet, weight control, all of that. So when starting out, what we'll usually start out with is our baseline. So a baseline of cholesterol, LDLs, HDLs, and then monitoring blood levels periodically. So the first anti-lipidemic medication we're going to talk about are our statins. So all these end in statin, 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 statin. And a lot of times what you'll do too is you'll have a combo medication, like you'll give lovastatin with niacin. Niacin is vitamin B3, and we'll talk about that as we continue. So the goal of this medication is to decrease synthesis of LDLs and vary LDLs and increase the synthesis of HDLs. So other beneficial effects include promotion of vasodilation and decrease in plaque site inflammation, thromboembolism, and risk of AFib. Therapeutic uses is mostly used for that hypercholesterolemia, prevention of coronary events, protection against myocardial infarction and stroke for clients who have diabetes, increase in levels of HDL, and primary prevention in clients whose LDLs is within the expected range. So with these medications, your complications are hepatotoxicity, so liver dysfunctions and myopathy. So you just want to make sure that you're monitoring your patients very closely or development of any liver dysfunction. So myopathy are your muscle aches, pain, and tenderness. And okay, so it can progress to myositis, which is inflammation of the muscle, or rhabdomyolysis, which is the breakdown of skeletal muscle. And the problem with that breakdown of skeletal muscle is it can cause like a cascade of other problems. So these medications can interact with your fibrates, and that causes the increased risk of myopathy. So you want to report muscle aches and pains. Other things it can interact with is your erythromycin. So it can increase the levels of some statins if taken concurrently. Grapefruit juice can also increase the levels of statin. So our bile acid sequestriants. So these are things like arcoll-stramamine, arcoll-stipple, arcoll-savolene. They're also called bile acid binding resins and ion exchange resins. Powder form may be convenient or well tolerated. So they'll usually have this in powder form. It's usually considered a second line choice after statins, and it prevents reabsorption of bile salts from the small intestines, and bile acids are necessary for the absorption of cholesterol. So colvalin is one of our bile acids sequestriants, and sequestriant is just a food additive which improves the quality or stability of food. It prevents reabsorption of bile acids from the small intestines. Indications can be relief of itching and type 2 hyperlipoproteinemia. Adverse effects include things like chest or constipation, heartburn, nausea, belching, bloating, but most of these tend to disappear after time. The next one we have is our question or our cholestyramine. And with this one is it can be used for the treatment of loose bowel movements, and you want to caution when administering dry powder. So with these medications, you can mix it with food or fruit. You want to mix it with at least 4 to 6 ounces of water. Make sure the powder is completely dissolved, but you want it to like kind of naturally dissolve. You don't want to spin it. And do not mix with a carbonated beverage. In NCLEX world, we avoid saying things like pop or soda or anything like that. If they're trying to tell you that something is a Coke, it's going to say carbonated beverage. And that's just their indication of telling you, hey, this is a soda, this is a Coke. So the other one is our niacin or nicotinic acid. So niacin is your vitamin B3. It helps to release energy from food we eat, supports normal nervous system function, fights fatigue, and helps keep skin healthy, is what that all does naturally. So it's inexpensive, often used in combo. It reduces metabolism or catabolism of cholesterol and triglycerides. Now, the thing about it is it can cause cutaneous flushing. So what you can do is you can give them a small dose of aspirin or an NSAID 30 minutes before to minimize that flushing. It can also cause itching and GI distress. Our last ones are our fibric acid. So these ones usually have fib in the drug name. So that's like our gemfibrozil and our fenofibrate. And these activates lipase, which breaks down cholesterol. It's used for hyperlipidemias. Its effects decrease the triglyceride levels, increases HDLs. So this is why it's counterindicated to take a fibric acid with a statin, because they both cause myopathy. The other thing it can cause is diarrhea. So you want to make sure you're watching your patient for any signs of diarrhea. Interactions include warfarin, increase the risk of bleeding, statins, increasing the risk of myopathy. All right, so that is everything. If you guys have any questions, like I always say, please feel free to send me a message. Thank you all, and I'll see you next week or this week, depending on which class you are.